Hello everyone. Prosthodontics on Friday to explain the prosthodontic process. As we are ushering in the colorful autumn season, the first speaker in October is Professor Song Young-gyun, Prosthodontics Department, Dankook University. Last time we talked about a guideline for functional implant prosthetic treatment in the posterior region. Today we are going to talk about considerations for implant prosthetic treatment in the anterior aesthetic region. This is broadcast live, so please leave your questions on YouTube. Answers will be provided in the Q&A session. I hope you participate in the discussion. Let me give you Professor Song Young-gyun. Hello, I'm going to talk about considerations for implant prosthetic treatment in the anterior aesthetic region. To make aesthetic implant prosthetics, I'm going to talk about contour, color, and materials. I'm going to talk about subgingiva control rather than white aesthetics. In the past, we used to look at the survival rate of an implant. However, now, it is not good enough to look at whether an implant remains in the mouth. Whether the implant is functioning or aesthetic needs to be considered to determine the success of an implant. Today, we don't just look at the white aesthetic. Soft tissue, the pink aesthetic is also analyzed to evaluate aesthetic implant results. Soft tissue becomes a parameter to determine the success of an implant. As you can see, the white aesthetic is good, but the surrounding area doesn't look very aesthetic. Therefore, we need to pay attention to something like this. Today, I'm going to talk about prosthetics only. However, surgery cannot be ignored. Surgical part and the prosthodontic part should be pursued together to obtain aesthetic outcome. Surgery should be done considering aesthetic outcome, and prosthesis can be used to compensate any missing parts. Soft tissue modification, we can do the CT graft surgically, and gingivoplasty can be used to trim gingiva. Prosthodontically, a customized provisional restoration is the only way to do that. Regarding the contour, we make a provisional restoration to contour, that is tissue modification or tissue molding, to get stable tissue, and that will be transferred to the final. The provisional phase is the most prolonged, most critical stage of restorative implant treatment. As you know, implant is placed in a missing area. The clinical crown should be estimated when placing an implant. Clinical crown needs to be designed in that respect. We need to concentrate on the position of the implant and clinical crown. There is a transitional part between those two. Sometimes it is called an emergence profile or emergence angle. Emergence profile refers to the shape, and emergence angle refers to the angle between the average tangent of the transitional contour relative to the long axis of a tooth. So those two words are used. In terms of the angle, gingiva height or diameter are used to explain the contour. Emergence profile, whether it is straight, concave, or convex, and emergence angle are not enough to explain them. There is more details to it. For example, the healing abutment, when we take the impression, it's formed round, but there is no round shape in the natural tooth. We need to pay attention to that. We make efforts to do surgery properly, but if it is not good enough, we need to use the prosthesis to compensate for that. We can push the soft tissue to mold it. What is the best way to create the emergence profile? Many papers say it should be similar to CEJ of natural teeth or root-like form to support ideal surrounding tissue form. Basically, this is what you already know. If you look at a clinical case, this is the situation, and provisional restoration is done using that. If gingiva gets more stabilized, individual impression coping is made to take impression, and abutment is made. Final restoration. It looks simple, but not everything is so simple. In the process of fabrication, the efforts of lab team is required. The lab team is basically focused on the white aesthetics. This is not a bad prosthesis. The contour is okay. Not only the white aesthetics. During the second surgery, CT graft is done. Over a long period of time, recession is expected. So the ceramic needs to be extended, and that is communicated with the lab. As expected, over time, gingiva had a recession, but the abutment is not exposed, and the shape looks okay. What I want to say here is that white aesthetics can be taken care of by the lab, but the overall situation, we need to identify and communicate a lot about that with the lab team. Basically, how I fabricate the provisional restoration, during that time, diagnostic wax-up is used by communicating with the lab, and connecting it and disconnecting it is minimized. Impression is taken, and diagnostic wax-up is made. Clinical crown and white aesthetics is left to the lab, and a lot of communication needs to be made with the lab. The condition of the patient should be shared with the lab. Sometimes when the stability is good, on the day of the placement, temporary abutment and artificial tooth can be delivered. Composite resin is used to adjust the form. And at the beginning, we don't need to communicate a lot with the lab. Communication is required at a later stage. The lab team looks at the instruction for the lab and the shape. They don't know about the bone level, so we need to communicate with them. In my case, I take the X-ray, and this is sent to the lab for the anterior as well as the posterior. So they know, they have the idea how they can control the situation. If you share the information, that will be very helpful. The existing form is okay. If the gingiva is receded for prosthesis, a temporary abutment can be adjusted. Provisional restoration can be adjusted to control the contour. The receded portion can be pushed out on the subgingival level. Let's look at a case. A 24-year-old female. The implant is placed. Everything is okay, except the problem. in the lip and on the labial side between 11 and 12, food is retained. That is the complaint. Between gingiva, the papilla is receded, and we made the adjustment. It is a core, so it's not filled up. I used a temporary. In the mesial side, the contour is made, over contouring, and impression is taken. Final prosthesis is fabricated, and it is delivered. If you look at here, gingiva is pressed down. Then it becomes like this. When gingiva is pressed down, the surgical approach could not resolve the problem, but the papilla is pushed out prosthetically. So prosthetically, we can help resolve the problem in terms of the pink aesthetics, not white aesthetics. So there is a way for prosthetics to resolve certain problems. When they cannot be adjusted, what do we need to focus on? In my case, I use screw retained restoration a lot. When gingiva can be pressed down, this has enough power to press it down. In this case, it is protruded a little bit toward labially, and screw retained is used if possible. If it is too much protruded labially, you cannot do that. Angled driver can be used to use the screw retained. In this patient, the anterior is fractured due to trauma, healing abutment, so the forms are circles, unlike the cross-section of a natural tooth. So it is waxed up. White aesthetic crown is taken care of by the lab team. From now, discussions with the lab team is activated as to which part will be pressed and how thin the platform will be. And the form is completed, is replicated to make provisional restoration. And over time, gingiva fills up and the shade is selected and sent to the lab. For the abutment, titanium customized is primarily used. On the zirconia base, it is built up, or pressed ceramic is primarily used. The original shape is used. The prosthesis carefully made. When the temporary is removed and the final is delivered, bleaching hardly occurs because the gingiva shape is maintained. The prosthesis is completed, satisfying the dentist, me, and the patient. The platform portion should not be made too wide. Aesthetically, you tend to apply too much pressure, then stability will go down according to papers. If it is too much flared up with high angle, you need to reduce it a little bit. Some implants has this type of concept, and healing abutment is used. The existing prosthesis cannot catch up with that. From the healing abutment to the final prosthesis, there can be difference. Healing can be done very well. When the temporary is made, the provisional cannot fit in, as the gingiva is solidly made, so they cannot be fit in, and you need to make the adjustment. For the provisional fabrication, you need to communicate with a lab technician, and screw retain type is good, and we need to be careful in creating the platform portion. Next color, you may know the glass art. It is not made three-dimensionally. Each sheet of glass has pictures drawn, and the sheets are all attached together, creating very beautiful art. We have many different shade selection tools, and we take pictures. This is green, but In the teeth, there are many different colors. Reflective lights can be interfering, and we need to eliminate the interference in selecting a shade. For anterior aesthetic prosthesis, a digital camera can be used to take the pictures. On the left and right, the colors look different. Polaroid film is used. There is a slit on one side. If they are perpendicular to each other, the reflective lights cannot pass through it. So, on the flash side and the lens side, you attach the film in perpendicular way. In selecting a shade, then the color will be more stable. The Polaroid film is very cheap. If you look at here, in the light, the film is attached, and in front of the lens, perpendicularly, it is attached. The reflective light from the teeth are all filtered out, and you can see true color of inside of the tooth. The reflective lights here are all eliminated. So like on the left, the white line or colors inside of the teeth can be captured. Upper and lower are taken with the Polaroid film used for the upper picture. Final prosthesis is delivered, and that looks very similar to natural teeth. We need to be careful when we select a shade. The background is dark, so we need to consider that. In this patient, due to traffic accident, stuck abutment needs to be used, and abutment shape is tapered, and that can be transmitted. And for shade selection, the picture is taken, and there is a discrepancy between the true shade and the selected shade. So the color inside is masked out, and when that is done again, the shade selected is to a certain degree acceptable. In this patient, existing implants created recession. With it, the crown of the adjacent teeth will be made again. Zirconia abutment, you can see discrepancy of colors. The prepared shade of the natural tooth and the shade of abutment should be matched. An IMAX or other system with good transparency should be used for more natural and beautiful prosthesis. Lastly, I would like to talk about materials. This patient had severe resorption. It's extracted, an implant is placed, temporization is done. After it is stabilized, the shape is created. It looks pretty good. However, on the top, the thin portion, the titanium abutment is showing. That is called shine-through effect. When the gingiva thickness is thinner than 2 millimeters, 100% of the cases, the shade will look differently visually. You need to check the thickness of the gingiva in selecting a shade. Next, to control the surrounding gingiva, titanium or zirconia have a better response from the surrounding gingiva. One more thing, zirconia can be used, but still there is a limitation in terms of aesthetics. So over it, ceramic can be built up, which is okay. But in the subgingival level, ceramic buildup would cause swelling of gingiva. So pressed ceramic can be the answer. Beautiful color can be achieved, and irritation to the gingiva can be reduced with that. If you look at it carefully, on the left, it's the built-up ceramic. On the right, is the press ceramic. On the left, the built-up ceramic has pores which interferes with the cleansing and cause irritation to gingiva. You need to consider that if it is located under gingiva. I talked about contour color materials. You need to give highest priority to the contour. For the white aesthetics, you need to communicate with the lab technician. This is all I have prepared. Thank you very much for your listening. Hello, thank you for your presentation. Professor, that was a wonderful presentation. I appreciate that. Before we take questions, this is your first time to the prosthodontics on Friday. What's your impression? These days, implant classes are focused on surgery, and I really appreciate prosthodontic focused program, and it is my honor to be here. Last time, Professor Lee Jun-seok talked about key points of prosthetics in the posterior region, and today, Professor Song talks about aesthetic prosthetic treatment for the anterior region, and I'm really glad to have you today. And I ask you to address the questions from the audience. Let's get started with Q&A. The first question, how do we restore the anterior prosthesis in a patient with severe gingival recession? Not only the shape, big embrasure space can be created. What is the wise way to treat that case? I prepared some slides regarding this question. So this is the question. If the embrasure spaces are large in a local place, surgically it can be resolved. If embrasure space is spread across the mouth, opening up the embrasure space can be an answer if the patient can adapt to that. And if we instruct the patient to take care of the oral hygiene, that will be okay. So even though the empty spaces exist, we can make it look natural by matching that, and we need to instruct the patient to clean the spaces. Due to trauma, or there is no bone and big spaces, I use zirconia frame to restore gingiva, and crowns are made over it. Beneath the zirconia frame, you need to be able to clean the space. That should be considered in designing this. So it should be designed for cleaning purpose as well. After prostheses are fabricated, prosthodontists focus on pretty aesthetic prosthesis before sending the patient home, but we need to instruct them how to take care of the oral hygiene and how to take care of them. What do you think? I agree. It looks pretty, but it should last for a long time. Yes, oral hygiene care is important to make it last long. The second question, customized impression coping is used for the aesthetics of anterior region. People say that, and I believe it is true. In that case, what is an easy way to fabricate the customized impression coping? For anterior aesthetic prosthesis, I use individual impression coping mostly. If you look at here, the analog is inserted in the block, This is not an easy way in my hands, so they can be copied, and I use different impression materials, and that doesn't make any difference. So I use fast hardening impression materials. Holding it, this is a screwdriver pin vise. You can connect it to the analog, and it can be a handle or holder. You can easily put the resin in hot water and take it out with that. So it's not sold in a dental store, right? You can get it in a hardware store. Yes, it's just a couple of dollars. Very cheap. Yes, I love to use it. Next question. During your lecture, in your PPT, abutment platform, the shape of it is said to be important. What do you mean? Especially in the bone level implant, at the platform portion, not much pressure should be applied. As you know, implant, unlike natural tooth, there is no PDL, there is no defensive membrane, so connective tissue barrier is created there. That portion should be free from applied pressure, and we need to facilitate the healing to create that smoothly. In my case, I don't apply pressure there, and space is secured. Repeated removal of prosthetic parts there can interfere with the creation, so I use wax up for the provisional. The gingiva surrounding the implant doesn't like to get the pressure, so we should not give stress or pressure on there. That's important. On the 7th of October, Professor Song delivered a lecture in the Wednesday lecture, and there was a question which was not answered, and I received a request again for the answer. If cement-type prosthesis is fabricated for anterior implant, it was inevitable considering the implant positions. Do you use the resin cement for the final cementation? In my case, for the final cementation, for the anterior region, I use RMGI cement. If you use the temporary cement like Tembon, they sometimes fall off, inviting a lot of complaints. One more thing, when you use provisional restoration, you need to be careful. You need to adjust. The gingiva margin is not too deep when you do the cementation. Teflon tape can be used for easy removal to reduce the worry for the excess cement. What is RMJ cement? Resin modified glass ionomer cement. It is a little bit weaker than the resin cement. If you use the resin cement, it is difficult to remove it. So it is a little bit weaker resin cement. Yes. Thank you very much. In real time, we received some questions. With the bone graft, if gingival line is different from the natural teeth, how do you restore? After bone graft, we do usually two-stage surgery. In the second surgery, CT graft can be used to address it surgically. Still, if there's a discrepancy, the ideal gingival level should be found, and the natural tooth can be adjusted. The gingival line of the natural teeth can be modified? Yes. Before we go to the final, we can go through the provisional stage to push out the gingiva as much as possible. Anyway, provisional restoration can play an important role aesthetically and for healing. So we need to utilize provisional restoration. Another question? If we use analog approach with the digital approach, what would be the advantages of that? I usually use analog as well as digital together. So when I do the diagnostic wax-up, analog approach is better because we can observe the details better. If I see it on the monitor, the detail, the differences are not manifested on the monitor very clearly. And for the fabrication, I switch to digital mode. So you use analog approach for the wax-up and switch to digital for fabrication. Is it more convenient? You may think it's more cumbersome, but sometimes we have to go back to square one when the situation is different from what I diagnosed. For subgingival control, the milling can be different depending on the materials. So in order to accurately transfer, digital approach would be better. I think the question is sufficiently answered. Professor Song, you gave us very good answers. Lastly, for those colleagues, dentists, who love implantology, do you have any advices? The basic concept of implant or a lot of knowledge is possessed by the dentists. However, we need to go through the lab team to reach the prosthesis. Efficient communications with the lab team would determine the final quality of the prosthesis. You need to think about how you can communicate better with the lab team for better prosthesis. In my view, digital dentistry is being advanced. Dentists would do the design and also do the milling. Of course, we can use the lab service for those. If we do all of those ourselves, we will have an opportunity someday. We will create everything that we envision. Thank you very much, Professor Song, to be with us today. Now it's time to close the prosthodontics on Friday. Those who joined us in the middle, not from the beginning, don't feel bad. You can go to www.dental.com. The address that is shown below, you will be able to watch from the beginning of today's program and also all previous programs. We'll appreciate it if you can use the site. Next time, we are going to invite Dr. Jo Young-jin, Seoul 뿌리 깊은 Dental Clinic, and he's going to talk about can we accept implant-assisted RPD as universal prosthetic approach. Thank you very much for staying with us until late hour. Thank you. Thank you very much.